So, good evening, all the aspirants present here. The topic for today is trauma and burn, and the speaker is Dr. Avishek Roy. He is an associate consultant ICU in Apollo Multi Speciality Hospital, Kolkata. Thank you, sir. So, you can start.
Good evening. So I'll be taking over the session of trauma and burn, and this is a huge topic to cover. So I'll be covering it in 3 days. First 2 days will be trauma, and burn will be covered in third day. And if there is any leftover topic of trauma, so I'll be take it in the third day. Burn will take around 45 minutes to 50 minutes, and so the next two classes will be mostly on trauma. So before going to the individual topics of trauma, I would like to describe something known as a triad system. So what is a triad system? So whenever we face a disaster like a mass casualty, something that we faced recently in Pahalgaon, so there initially they will announce a triad system whenever the military personnel along with the medical staff reach the system. So what is a triad? It is a quick way to segregate victims or patients based on their severity of injuries. And the most important part of triage is that it has to ensure that the proper or immediate attention is to be given to the ones who would benefit from the management the most. This is the basic baseline. So immediate management is given to the ones who would benefit the most. The reversibility is the most important factor, or rather the time essence, urgency is very important. So according to triage, we have got various code systems. So red is for the ones who would be immediately attended, that is immediate red. Yellow is urgent, but they can be waited. So they can be made to wait for around few hours, like 6 hours to few around 12 hours, but they need some attention. And green are the ones who can be safely discharged or they can be seen later on. They are requiring the primary aid for first aid. And then you get some blues, which are basically on hold. They're expected management. They are kept in the holding area. And the code black is dead. So they're expected to be dead or they are not given any sort of care. So this triage system is very important. And the triage can be done at different levels. Like it can be done at the site of trauma. For example, if you have a trauma, if there is a mass casualty, if there is a bomb blast, or there is a sudden onset chemical exposure, in those cases, there are particular precautions like decontamination at the site has to be taken. The major life-threatening, life-saving procedures have to be done, like airway control, bleeding control, and tourniquet application, etc. Moving on from that immediate place of attention or immediate place of affection is that the patients are now mobilized to a much safer, relatively safer zone where they will be having a disaster area containment zone. And then again, they are triaged at the disaster area where they are triaged again based on their severity of injuries into red, yellow, green, and then black. And the medical team here evaluates the patients and they go for the fluid management, they go for application of tourniquet. If it is not done, they will go for the primary survey and the secondary survey and diagnose any kind of life threatening injuries. And subsequent to that, they will go to the evacuation track. So afterwards, supposedly the incident has taken place in Kashmir, but the nearest trauma center is there in Delhi. So immediate trauma triage has been taken place at the site where the disaster has happened. For example, if it was a playground or it was a tourist site where the disaster taken place, first triage occurs there. From there, they go to a nearby hospital where the second stage triage happens, and then from there, supposedly, few patients have to be airlifted or by the by road or by flight. They have to be transported to some other facilities. Then we have something known as an evacuation triage at that stage also. There are different systems in order to evaluate who has to be managed first. And there is a disclaimer before going into this step. So why is trial
అదే
system important?
లాస్ట్
Before
ఇస్తాను గెట్ అరే
going
ఏ
into
ఫోర్ సైజ్ పేపర్స్ అను పెన్ తీసుకోండి మీకు ఇంప్రూవ్
uh,
అయిందా
before going into the details of primary survey, why is triage important is that many a times when patients collapse or they have a cardiac arrest, we go for CPR, right? Everyone knows that. But if you are performing CPR in a triage scenario, in a disaster scenario, you don't know how to manage a casualty or mass casualty or a disaster. There is no place or almost no place, I would not say no place at all, but almost no place of doing a CPR in a triage system. So if a patient is such in a such catastrophic state that they cannot be revived, you simply declare them code black, unable or expect, or they won't be revived, and then you move on. You don't perform a CPR and waste time. You have to cater to the larger group of patients. Now, how can I, just looking by the patients, ascertain whether the patient is severely compromised or not? There is something known as a START system, which stands for Simple Treatment and Rapid Transport, where they have a 32 can do. That's what is 32 can do. Supposedly, a patient has come. You see that the patient is not breathing. You position their way. What we do first? Supposedly, there is a casualty side. You see that some group of patients are very minor. They can walk, so they are group, yeah, green. So they are green triads. They can be primary aid and then discharged. Then some group there. Then some patients are not breathing. So you will position their way. You will make them lateral. You will go for the head tilt chain lip position and see if they are breathing or not. If they are not breathing, don't go for CPR. Go for, they declare them dead. If they are breathing, now you have to apply the 32 and can do rule. What is 30? If their respiratory rate is more than 30, if that is there, or if the patient is having a capillary refill of the perfusion that is less than or more than 2 seconds, and they are not able to follow commands, so they are having a respiratory distress, they are having poor perfusion, or they are having altered sensorium, either of them is there, then we have to declare them as red. So they have to go for immediate management. See here. So after the spontaneous breathing phase is over, now they're spontaneously breathing but respiratory rate is more than 30, they are going for immediate management. If they're less than 30 but perfusion is more than 2 seconds, they go for immediate. If less than 2 seconds, and mental status, if they're altered mental status, they go for immediate. And if all the criteria are negative, they still go for the yellow ones. So not for the green. So green are for the walking wounded. The green is also called as a walking wounded. Similarly, in pediatrics, there is something known as a jump start. Jump start is applicable to someone who is riding a two-wheelers, they will know that. So in cases of a pediatric system, there is an addition of 5 rescue breaths before you declare them code black. So immediate in adults, we had this step that position airway, no breathing, you declare them code black. But in pediatrics, if despite the positioning they are not breathing, first you give 5 rescue breaths, because airway compromise is the major cause of cardiac arrest in pediatrics. And therefore, if you give some oxygen and their respiration resumes, that means they can be saved. So you give 5 breaths. If they are not breathing, you declare them dead, and they are breathing, then you go for immediate management. That's a basic triage. There is something known as a C1 sort system, almost similar. So I will not go into the details of sieve and sort. The last thing about triage to know is that it can be done at different levels. There are different scoring systems or assessment system like start, jump start, etc. And it can be done by many person. It can be done by the nursing staff. It can be done by the doctors, and it is done at the site of trauma, at the site of medical management, as well as at the site of evacuation. Now, coming to the next part of our topic is that uh, what are the scoring systems in trauma? For example, I want to know that a patient who is having some minor skeletal bone fracture, long bone fracture, versus someone who has undergone a major abdominal trauma, someone has been run over by a vehicle. So the scoring systems are the ones which designate how much severity is there to a particular patient, along with resource allocation and prognostication. So different scoring system, we have to know these two, ISS and AIS. ISS stands for injury severity score, and AIS stands for abbreviated injury scale. Whenever there is an injury occurring, supposedly we have an injury suppose a patient has polytrauma. What is polytrauma? Polytrauma is defined as when you have at least two or more different sites involved with respect to trauma, and the AIS score, it is more than equal to 3. So if there is an involvement of two or more sites with AIS score more than equal to 3, we call it polytrauma. So AIS is abbreviated injury scale. Supposedly you have a trauma over the hand. It can be having a superficial wound, or it can be having a deep muscle deep wound, or it could be completely mangled with blood vessels exposed, muscles exposed, and bony fracture. So the AIS is designated as 0 to 6, and the most severe ones are given the 6 score, and the most minor ones are given a 0 score. So from 0 to 6, the severity increases. And this is given to a particular area. So for a head, there is an AIS. For chest, abdomen, different system has an AIS. And once you square them up, supposedly in abdomen you have a score of around 4, and in chest you have 3, and in limbs you have 4. You square them up and then sum it up, then you get something known as the ISS. The ISS is of the total body, AIS is of the particular affected limb. So you have documented the
Yes,
trauma
Anaya.
injury and then ISS and IIS. There are some other scoring systems which are
बैठो
also
पहले बैठो नीचे बैठो नीचे
prognostication, like the revised trauma score. Revised trauma score are physiological scores. So other than the blood pressure and everything, we have to know that the patient has to have a altered sensorium is there or not, and what is the respiratory status. Revised trauma score has three components: GCS, SBP, and RR, that is respiratory rate, and these three are equivalent to QSOFA, the quick SOFA score used in sepsis. There are different values. How it is calculated, not required. You just have to remember the scored name, revised trauma score. And there is something known as a blast injury severity score for blast trauma lung. So if there is a lung injury, lung blast, blast injury following a
come
subsequent
this side.
pulmonary contusion or some
It'll be equal.
pneumothorax, it
Come
can
this
be
side.
calculated based
There
on
are two
blast.
this side and two this side should be there.
Now, coming to the other scoring systems, for
Yes.
mangled extremity,
पैर
we have
ठीक
got
रखो.
extremity scoring system by Gastilo Anderson, and then again
ठीक
we
से
had
बैठो.
got two
हाँ.
accident severity score, which are different other than the usual scoring system that
हाँ.
is used. Pediatric trauma score are there. For example, the PTS pediatric trauma scale. Then you got big score. BIG stands for base deficit, INR, and GCS. So it is calculated based on the three scoring systems. So you can see that there are various scoring systems which are also based on physiological or rather ABG based parameters like the base deficit. And this is very important when we go on discussing about the further things on trauma management. So how the base deficit is very important in especially in hemorrhagic shock. Now coming to the main clinical part of trauma. So I'll be discussing first the trauma management, the primary survey, and then I'll go on to the next parts. So primary
Enough.
survey is somebody's, I think, voice is coming. Can someone mute it? I think there is some background noise. Okay. So what is primary survey? So this after discussing uh, the triad system and the different scoring systems. Now a real-time scenario. Supposedly a patient who has been brought to the emergency, who has undergone a motor vehicle accident some 2 hours back, and there was a motor vehicle, a two-wheeler, got struck by a truck. He was found obtunded. He was having bleeding all over the area. He has been brought to the emergency department. And you see, how will you approach the patient? So this is the first case. Whenever you see approach a trauma patient, you have to apply the primary survey. And then you have the secondary survey, and then you have the tertiary survey. The primary survey is to address the major life-threatening injuries and the major problems that you are going to deal with the patient. And it has a mnemonic that is A, B, C, D, E. What is A? A stands for airway, B for breathing, C for circulation, D for delirium or disability limitation. They're basically looking at the neurological status. E for environmental exposure. So A stands for airway. First, you see whether the patient is having a potent airway or patent airway or not. If the patient is, what are the signs that the patient is not going to have a protected airway? If the patient has a completely obtunded status with severely reduced GCS, a GCS score of less than 8 or motor GCS drop of more than 2. Patient had a baseline GCS of say 15, but now you are looking at a GCS within half an hour of 13 and motor GCS drop of more than equal to 2, could be a sign of head injury, obviously. Or if there is a significant facial trauma, there is something which has hit the face and the face is mangled, severe facial injury, or there is a neck injury. In all these cases, the airway is threatened. What can happen is, in these cases, you want to secure the airway first. So you have to secure the airway means putting an endotracheal tube. So before that, I'm not going to the details of how you are going to intubate per se, but you have to secure airway in these cases where you have a obtunded patient with low G sensorium, or you have a severely neck or facial trauma, which can cause a significant loss of airway. Second thing which has to be said, you have to ask the patient their names and their whereabouts and see their sensorium. Other than the fact, you have to notice their voice. If they have a choking voice, if they have stridor, that might indicate they have obstruction. And the obstruction could be from some foreign objects, could be dentures in case of elderlies, or it could be blood clots, anything that is stuck in the airways. And very important to identify a change in the voice or a stridor in the voice, because if you are going to intubate and if you are blindly introducing your DL, that's a direct laryngoscope, you might end up pushing the foreign body further downwards into the trachea or the esophagus, and that is going to be detrimental. So you have to identify those. You have to do the triple maneuver, so that's the chin lift, jaw thrust, and the head tilt. The triple maneuver you have to do, and you have to keep these points in mind. So do they have an obstruction? Do they have a grunting sound? Do they have a stridor? And all patients must have a cervical corner on unless you have ruled out a cervical spine injury. For cervical spine injury, you have to have a cervical Canadian C spine rule or a Nexus spine rule. So these are all declared ruling scoring systems or assessment systems, whether or not you are going to evaluate for the cervical spine. And by means of evaluation, I mean CT scan. Whether you go for a CT neck before removing the collar. Very basic to remember. If the patient is completely oriented, communicating, they can tell you, I don't have a pain in the neck. Second, they are telling you that they don't have any tenderness, both anterior or posterior, and they can rotate their head nicely from side to side without having any pain complaint, and they don't have any paresis, they don't have any neurological deficit. They can be safely said, okay, their spine, cervical spine at least is normal, and you can remove the cervical collar. If none of any of them is not met, that is, patient is obtunded, you have to apply cervical collar, go for a CT. Patient is saying that the patient is having significant throat pain or restricted mobility, or patient is having thoracic, abdominal, or any limb paresis. That means the patient is likely to having a cervical collar, cervical spine injury. In all these cases, whenever you are going to intubate, so you have to put the collar. Now you have to apply something known as MILS, that is manual inline stabilization. So manual inline stabilization is a technique where a second person stands across the person who is intubating and pushes, or rather applies opposite force as to the direction of intubating force, so as to reduce the cervical trauma. Again, I'll repeat. Supposedly I am standing on the head end. Somebody has to stand either from the patient's right side or by my side, and they have to put their hands just around the neck. So their palm should be over the mandible and over the mastoid, and they should be holding the neck, or they can hold their hands below the neck and they can hold their spine. So hold this neck jaw. So they have to hold the jaw still during intubation, so as to prevent an extension injury. If you have a cervical spine fracture and if you are hyperextending the neck, you are mostly likely to have a cervical spine injury. So important to remember in airway management, other than the previous points, if you have a cervical collar, keep it on unless you have ruled out a cervical spine injury. And during the collar, if the collar is on, if you are intubating, you can remove the anterior part, but you cannot mobilize the neck. You have to ask a second person to hold the neck, and that is called a MILS, Mills maneuver. And in these cases, like cervical spine injury and suspected difficult airway, always ask the senior most person to intubate the patient and ask for a adjuvant of airway management like bougie, like video laryngoscope. Very important that in these cases you can use a video laryngoscope and without using a direct laryngoscope and putting pressure on the neck. So these are very basic things to know. Second thing, very important, and I want everyone to focus this point. This I've taken from a chapter that I've written recently, so it's not particularly in a PPT point, but it is a very important point. In a patient with deranged physiological variables, means hypotension, altered sensorium, hypoxia, if you want to intubate and you intubate frantically, suppose patient saturation is dropping and you intubate immediately, and the patient is will definitely going to arrest. So in these cases, you have to ensure that patient is properly ventilated and oxygenated, and then only you have to go for intubation. And to ensure a proper ventilation and oxygenation in a patient who is completely obtunded, hypotensive, and completely not cooperative, is to give a minimum sedative dose. And in this case, you have to give the safest choice is ketamine. You have to give a non-sedating dose of ketamine at zero point 0.1 to 0.15 mg per kg. That will be like 10 to 15 mg of ketamine. And then you have to give a full intubating dose after 3 to 4 minutes of that dose. The initial small dose of ketamine will calm the patient and will help you to give proper pre-oxygenation prior to intubation. That is, this step is known as drug assisted or drug induced intubation, delayed sequence induction or drug associated intubation. So this step is known as DSI, delayed sequence induction, or DAI, drug assisted intubation. So you give a small sedative dose of ketamine, you oxygenate the patient, and after 3 to 4 minutes, you give a full dose of ketamine along with a paralytic agent and intubate. This has been shown to reduce the chances of hypoxia after you have secured the airway. So this is come in the recent ATLS 10th edition. This drug assisted intubation is very important, and it has been mentioned. Next part after airway is secured is breathing. So in the breathing, what you will check is you will assess for any signs of inadequate ventilation. How will you look out for signs of inadequate ventilation? By looking at simple auscultation, percussion, palpation. So they're basic things: inspection, palpation, auscultation, and percussion. Now, we don't do percussion always, and we only do an inspection, palpation, and auscultation in most of the cases. So what we do, we do percussion is in few cases, but it has to be very quick. So you have to see the adequacy of chest wall movement. You look at the patient, you see that the one half side of the chest is not moving. That means the patient is mostly having a right sided or that particular sided trauma. Could be an air, could be fluid. So that is a sign of inadequate breathing. Are there during palpation, if you see that the one of the same with inspection and palpation, if you see that the one of the chest side is not moving adequately, means there has to be some problem. If you see that there is a diminished breath sounds on either side due to either air or it could be fluid. If you have air, that is pneumothorax. If you have fluid or blood, that's hydrothorax or hemothorax. It can also be because of lung contusion where one side there is decreased air entry. You can have see the deviation of trachea. The trachea is deviated from either side midline. That means there could be a tension pneumothorax or there could be a bleeding vessel, huge hemothorax pushing the trachea to the contralateral side. On inspection, you can look at an important clinical finding in thoracic trauma, that is flail chest. That is, I will discuss in details about flail chest later. And during this step of evaluation of the breathing, we have come altogether quite we have advanced in the recent years, and we don't rely only on our clinical science and judgment. We have got ultrasound to use bedside, and whenever in critical care, in trauma, in emergency, you have a chance, a slightest chance of using the ultrasound, you use it. So in trauma, when we use it, it is called as FAST, focused assessment sonography in trauma. So when we are using FAST, it is mostly meant for the abdomen, and there is a particular variant known as EFAST. EFAST stands for extended FAST, where along with the abdomen, we look at the basis of the bilateral chest. And if by looking at the chest, we are trying to understand whether there is an air or the fluid. So if you find there is an air in the, or there is absence of lung sliding on the chest, that is suggestive of pneumothorax. And that is a particular sign, not my topic today. But if there is absence of lung sliding, or if you see that there is some fluid in the pleural cavity, that means the patient is having either of them, like pneumo or hemothorax, and you have a chest drain. So always use an ultrasound along with your primary survey to reach to a definite diagnosis faster. After you have done with the breathing and the ventilation, so what can be done with the breathing? Like airway, you have to put a tube, intubate the patient. In breathing, if you find that there is any diminished air entry or blood in the thorax, you have to put a chest drain.